Okay. Sorry, I think my system was hanging. My system could not handle the whole recording process. So that's that for that. But what I want to also stress in I think we are done with penicillins. What I also want to also stress is the combination with amoxicillin. Now, recent antibiotic combination has seen us combine amoxicillin with other medication. You understand? So you can check that personally to see. But the major brand we have for amoxicillin and the clavulanic acid is the Fleming and the Fleming and augmentin, coamoxiclav and the rest. So majorly penicillins have a major notice concentration is that penicillins have allergies. About 1 to 5% of people have allergic or are allergic to penicillin intakes. Okay, and this can be very life threatening. Then one other thing you have to also know is that the next class of antibiotics we are going to go is the cephalosporins. Cephalosporins and penicillins. That is people who are resist or have an allergy to penicillins. We also likely have allergies to penicillins. About 10% of people. So please remember these figures. 1 to 5% are allergic to penicillins, and about 10% of those people that are allergic to penicillins will also be allergic to cephalosporins. All right. So there is a cross sensitivity or cross reactivity. The reason for this is because penicillins and cephalosporins they have similar structure. All right, they have a similar ring that is common to both penicillins and cephalosporins. All right, so major side effects of penicillins are diarrhea, and sometimes diarrhea that is caused in penicillins as a result of the combination with clavulanic acid. Clavulanic acid usually causes diarrhea, gastric irritation. Okay, there is also nausea, and there is also anaphylactic reaction. Anaphylactic reaction is usually more common with the IV um, with the IV medication route of administration of penicillins. Okay, then take on empty stomach. All right, that's for the normal penicillins, the amoxicillins, the natural, the penicillinase resistant, then the aminopenicillins. However, for the combination, you take with food because if you take on empty stomach, it's going to increase the chances of gastric irritation that can actually harm they cause more discomfort for the patient. So the next class of drugs is the cephalosporins. Cephalosporins, as I've mentioned before, are related to the penicillins. Okay, they have about 5 generations. Okay, now each generation of the cephalosporins, they have major specificity. They have major uniqueness. So just pay attention to the generations. Okay, so the first generation we have cephalexin. Cephalexin is one of the first generation of cephalosporins. All right, they majorly act against gram-positive bacteria. All right. Then we have the second generation cephorozim, what's popularly known as Xenax. Cephorozim, all right, they have broader spectrum of activity more than the first. All right, they are usually very good for respiratory infection, that is the upper respiratory tract diseases, pneumonia, ears, nose, and throat infections, and the rest. Then we have the third generation, which is the ceftriaxone. Ceftriaxone is the third generation. All right, and they're mostly available as IV. Okay, they are used basically for UTIs and several serious upper respiratory tract infection. Okay, then sorry for that noise. Then when you're taking the third generation, you should avoid taking medications that contains calcium. Okay, because of the reactions that come up with the combination. Now we have the fourth generation, we have cefepime. Cefepime is usually restricted to hospital use. I don't think you can find it in any pharmacy. Usually release it only to hospital to manage what they known as superbugs. Superbugs are usually bacteria that are resistant to a broad range of antibiotics. Usually, no antibiotics can act on them. So these ones are usually this class, fourth and fifth class of cephalosporins are usually reserved for that. All right. Example of the fifth class, we have ceftaroline. Ceftaroline is quite very expensive and reserved for only resistant cases. So what they do now is that when they make new antibiotics, they don't usually release them to the public. They usually keep them from reserve, and their price is usually very high, so that they can be used to fight resistant cases infection. So common side effect of cephalosporins is diarrhea, rash, and then there is also the cross 10%, 10% patients who are who are resistant or who have allergy with penicillins. We also have allergy with what? Cephalosporins. All right. So that's that. So the next class of antibiotics we have of antibacterial is macrolides. All right. Macrolides are usually safe for patients who are allergic to penicillin. So if you have allergic to penicillins, we will not give you cephalosporins, but we can give you macrolides. Okay. They are bacteriostatic in the sense that they do not kill bacteria; they just only stop their growth, while they allow your body the opportunity to what to kill them off. You understand? So they stop the growth of bacteria while the body eliminates them eventually. All right. So example of common macrolides are erythromycin. Erythromycin is one of the oldest macrolide that we can find, and the doses are usually 6 hourly. Please, macrolides, erythromycin is 6 hourly. Sorry, 6 hours, that's 4 times a day. 6 hourly, please. Note that I've seen many prescriptions that place erythromycin as 8 hourly. I can also ask you in your case studies, what is the recommended duration for erythromycin, please? All right, 6 hourly, and you have nausea, vomiting, um, abdominal cramps, diarrhea are usually part of the side effect of erythromycin. All right. Then we have the azithromycin. Azithromycin is more like an improved version of erythromycin. Azithromycin is 24 hourly. You understand? As against erythromycin that is 6 hourly. Erythromycin 6 hourly. Azithromycin is 24 hourly. All right. Usually for soft tissues infection. All right, soft tissue infection. It can be used for typhoid. It can also be used for STIs. It can be used for skin. It can be used for throat infection and other upper respiratory tract infections. Okay, and usually the dose are usually 24 hourly, and sometimes as simple as 500 milligrams starts, 1 gram starts, is enough to clear up any infection. Depends on the peculiarity of that infection. Then we also have clarithromycin. Clarithromycin is also another class of the macrolides. Then side effects of macrolide usually abdominal pain, diarrhea, nausea. All right. Now they have severe liver toxicity. Although this one is rare, some macrolides can cause severe liver toxicity. They can also cause temporary hearing loss. All right. Those are good nursing consultation for you to pay attention to. So the fourth class we're going to talk about are the fluoroquinolones. Now for the macrolides, if you pay attention, you will see that their names mycin are quite present in every of the class that was talked about. All right. Then we have the fluoroquinolones. Fluoroquinolones, they're usually very broad. They kill. They are not bacteriostatics, unlike the macrolides. They kill eventually, and they have very good oral absorption, that they can be absorbed from the oral route very fast. All right. One of the example of fluoroquinolones, we have the ciprofloxacin. All right. Fluoroquinolone is used for bone infection because it's absorbed into the soft tissues of the bone. It's used for gonorrhea. It's used for typhoid. It's used for UTIs and the likes. All right. You can take with or without water, with or without food, but when you take them, you have to drink a lot of water. All right. Then when you take them, you also avoid milk products, any antacids and the rest that are going to reduce the absorption of the product. Okay. We have the levofloxacin. Ciprofloxacin is one of them. Then we have levofloxacin. Levofloxacin has a broader outreach than ciprofloxacin. Okay. Then, however, ciprofloxacin is taken 12 hourly. Levofloxacin is taken once daily. Then we have the ofloxacin. Okay. So if you pay attention, you see the zacin for the fluoroquinolones. Then we see the mycin for the macrolides. All right. So that is that for that. Then one other class of drug we are going to talk about is aminoglycosides. Now, please let me mention for the fluoroquinolones, you do not use in children under 18 years. You do not use the pregnant women. You do not use breastfeeding mothers. All right, because of the side effect that it has. It can cause confusion. It can cause seizures. It can be, if it's used in children. Okay, it can cause um, damage of the tendon. Okay, that is pain around the tendon. You know where the tendon is. All right, locate the tendon for your own understanding. So example of aminoglycosides, we have gentamicin. Now, basically, this class of drugs, they are bactericidal. So far, we've seen two classes of drugs that are bactericidal. Okay, uh, what they do is that they don't kill, they actually stop the growth and replication, and then the body destroys them. All right. Now, the aminoglycosides basically are not absorbed orally, so they're only present as IV or IM. So that's why we have gentamicin injection. I don't think any one of us have seen gentamicin tablet. If you have seen, let me know. They are used for many illnesses, all right? Meningitis, endocarditis, complicated UTI, urinary infection, all right? But usually, because of severe resistance, they are usually used alongside other medications. Then we also have amikacin, all right? The uses also cut across the same use with gentamicin, okay? So when you're administering medications like gentamicin, ensure you always add other antibiotics to it. And one of the major side effects of the aminoglycoside is nephrotoxicity, kidney damage, okay? So you have to watch the way you use it. Then we have the ototoxicity, ear damage, that is can cause damage to the hearing loss. There is also neuromuscular blockade, all right? It can reduce or it can stop nerve movement and nerve signaling. All of this can lead to a condition called myasthenia gravis. Now, noxious concentration before giving gentamicin or any of the aminoglycoside, amikacin, gentamicin, ensure you do what you check kidney function. Then check if the patient has had any issue with hearing. You don't want to give somebody permanent deafness because you administer aminoglycosides to the patient. All right. So the sixth class of antibiotics we'll talk about is tetracycline. All right, broad spectrum, but bacteriostatic. Tetracycline, the example of drug in tetracycline class is also called tetracycline. All right, it's usually used for skin infection, soft tissue infection like acne. All right, then it's also used for cholera. It's also used for H. pylori infection. All right, in ulcer. And then we also have doxycycline. Doxycycline is also an example of a tetracycline. Tetracycline is administered 4 times a day, which is 6 hourly, okay, four times a week, which is actually 6 hourly. Then it's administered on empty stomach in order to increase absorption. However, the other example of the class, doxycycline is administered 12 hourly, all right, and you can take it with food, okay. It's also used for almost similar things that we use for tetracycline for. So if you notice, I'm just trying to speed talk on each of the classes so that you can have an idea and then be able to read it. Now, one of the major side effects of tetracycline class of drug is that they can cause photosensitivity. That is, when you take them, your skin is sensitized to the sun. So it can cause patients to have sunburn. Then if it's given to children under 8 years or taken in pregnancy, it can lead to teeth staining. That is, the child can have stains in the teeth. All right, that is what they call soft tissue discoloration, bone marrow discoloration. You know, your teeth is an extension of your bone. So the color that your bone takes, that's the same color your teeth will take. So when you take this medication, the tetracyclines, they get absorbed and they give permanent stain into the bone marrows, and those things reflect in your teeth. So you see children being born or children growing up and their teeth are permanently discolored. It may not be because of poor oral hygiene. It may be because of tetracycline being taken during pregnancy or being given to them when they were babies or when they were a child. Tetracycline also avoid bone growth, so you avoid it in children. All right. We do not use for children under 8 years. Do not give to pregnant women. Do not give to breastfeeding mothers. So if I give you a case study and you see tetracycline mentioned there, one of your most concentrations is to withdraw it, especially if the child is below 8 years, and also especially if you say breastfeeding or pregnant mothers. All right, this next class of drug that we have here, we have sulfonamides. I think sulfonamides. Example, we have sulfonamides. We have Septrin, the one we popularly call Septrin. Septrin is a combination of sulfamethoxazole and trimethoprim. They work together to give synergistic effect, although there's severe resistance to drug in this class. Okay, that's why basically I'll just keep a little about that. I'll talk more on that. Okay. Then I think number 9 here we have chloramphenicol. Chloramphenicol is effective, but it's also severe resistance to chloramphenicol as an antibiotic. Okay, it's used for typhoid, it's used for eye conditions, and although it has some uses, I think most of the use has been subjected to topical like eye drops and the skin and the creams. Okay, but it has some severe side effect anyway. It can cause stop. It can suppress the bone marrow and stop the production of blood cells. It can cause what they call gray baby syndrome if you use for children. So you avoid chloramphenicol. All those chloramphenicol you buy for children when they are having chloramphenicol eye drop, you buy for children. Although the drops are quite very minimal, but it can also cause issues in children. That gray baby syndrome can be very fatal. All right, so it's avoided in children and babies. All right, so that's that for that. That's for that. Any question should be channeled to any question should be um, channeled to the comment section, or you ask me, or you get my number from your class rep and send to me, or we'll do a voice note for you, and then probably if I need to maybe revise if the question is actually, and then if the question is actually throwing more light on part of the topic, I can do a review and maybe mention it in class. So your questions are very, very much welcome. One other thing you should know is that antibiotics, basically, all these antibiotics I give to you here, all of them basically work synergistically. That is, they combine together to improve the outcome. So you will hardly see a doctor prescribing only one antibiotics. They will prescribe many antibiotics, sometimes two, three, or four, depends on the severity of the illness. You understand? So what they do is that they combine all of that to prevent resistance. Okay. So generally, as a nurse, what do you need to pay attention to? Just pay attention to allergic reaction. Sorry, pay attention to allergic reaction. For example, I mentioned penicillins and cephalosporins. There is cross allergic reaction. So if some patient is having allergic reaction taking penicillins, they will also have taken what cephalosporins. Good. So you should know that. And what you also know that antibiotics, before you take antibiotics, you have to also do what they call sensitivity culture test. You don't just give antibiotics like that. So if I'm asking you a case study in the exam and I'm asking you which antibiotics you need to do, one of your questions should be, I'm going to carry out the sensitivity culture test to be able to determine the safest antibiotics, which is a very good response. So you don't just prescribe antibiotics like that over the counter, which is not correct. All right. So all of these culture tests are necessary for the prescription of antibiotics. So to also give some antibiotics, you also have to check kidney and liver function. All right. You have to check kidney and liver function. Then you also know that some antibiotics have more risk of causing anaphylactic reaction, like penicillins. I told you the penicillins, the IV can cause anaphylactic reaction. So you have to ensure that when you're giving medications, especially antibiotics, you do what? Especially penicillins, you ensure you are giving them, especially if they're IV, you are giving them in a hospital facility where there are emergency procedures in place to ensure this patient is well and properly revived. All right. So that's that for that class. I think it's at this stage we'll move to the case study. So case study one, artemisinin-based combination therapy. We have Chisom, 7 years old, complaint, fever for 2 days, body pain, poor appetite, temperature above 39, malaria test positive. Okay, prescribe artemether for the patient. So the question is, why is combination therapy used instead of single drug therapy? Question two is how should artemether be taken for best results? Question three is what should you tell the mother about completing treatment? When should children return to the clinic? Sorry, what preventive measures should you teach the? Okay, so that's a very good set of questions. Now, class, most of these questions that have been asked are basically nursing consultation about malaria or about anti-malarials in general. So why do you combine a drug? I mentioned the first reason to combine a drug is for what? Is for to prevent drug resistance. All right. Now, when you combine drug, you have a better chance of curing the malaria. Okay, you cure the malaria you have a 90%, then 5% chance of curing the malaria. Okay, how to take the next question is how to take antimetal. You take with food, fatty foods especially, because it increase absorption 2 to 3 times. So those persons that are taking antimalarial on stomach will likely not get the same level of cure or the same level of effect as those who take it with food. So how is it taken? Artemether is taken 8 hourly first, then before you start doing 12 hourly. So if you take the drug now, you take the next 8 hours. Then after that 8 hours, you now start taking 12 hourly. All right. So That is how it is taken. What to tell the mother about completing the drug? Okay, if you stop the drug early, it can lead to resistance. All right, and then the parasites, the malaria parasite, will survive and start multiplying again. Okay, so ensure that the child completes the dose. All right. So the child should only come back to the clinic if, that's the next question now, if the fever persists after 3 days. So after 3 days, if the fever persists, the child should come back to the clinic. All right. Then preventive measures: sleep inside insecticide-treated mosquito nets, stagnant water, grasses should be cleared, and close doors and windows. All right. So that's basically it for anti-malarials. Now, you see how simple those responses are, but they are very important for you in your nursing consideration, especially when you are going to administer care to patients in the ward, or when you're in an exam condition. So the next case study question, we test our knowledge on benzoimidazoles. All right, name Fatima, 5 years old, school deworming, giving albendazole 400 milligrams single dose. Mother asks, is this safe? When will the worm come out? All right. So question one, what type of worm does albendazole treat? I mentioned that. What should you tell the mother about how albendazole work? Do you need sugar? Do you need to fast? You know, some persons will tell you before you take one medicine, you ensure you do not eat, blah blah blah, and the rest. How often should children be dewormed? Why? What hygiene practices prevent worm reinfection? Are there any side effects the mother should watch for? I think I mentioned all of this during when I was mentioning anti-helmets. So basically, the albendazole, they just ask you details of albendazole. So the types of worm albendazole treats: roundworm, hookworm, pinworm, tapeworm. All right. Generally, let me just give you a code. Albendazole will cover any intestinal worm, or sorry, most of the intestinal worm. Most of the worms that stays in the intestine, albendazole will cover it. I think that should make sense. All right. So you have to start cramming this and that. All right. So how does it work? Basically, worms will not come out when albendazole is used. All right. The dead worms are broken down and absorbed by the body. You break them down because they are nutritious. Sorry to say that. Body absorb them when they are broken down and destroyed. All right. So the albendazole work by blocking the neuromuscular system of the worms and prevent them from movement. When movement is prevented, they are unable to transfer nutrients from one part of the body to the other and eventually die off. All right. So you can also tell the mother that if the mother is insisting, or you just explain to the mother that, see, oh, after taking this medication, the child will not pass out worm or may not pass out worm. If it pass out worm, don't be scared. If it doesn't pass out worm, doesn't mean the medicine have not worked. You understand? So the patient actually feel like the child has to pass out worm for them to be sure that the medication has worked. So how often should you deworm? All right, you deworm every 6 months. All right, every 6 months or twice a year. All right, then hygiene, personal hygiene: wash your hand, wear shoes, cut fingernails, wash fruits and vegetables, and drink clean water. So side effect to watch is stomach pain, small stomach pain anyway, nausea, vomiting. All right, those are the little side effects that come with ingesting or taking albendazole. I hope that answers every question. So if you have more questions, just let me know. So praziquantel, Mr. Ibrahim, 35 years old, fisherman, blood in the urine for 3 months. That's schistosomiasis. Blood in the urine for 3 months, low abdominal pain. All right. So the drug that was prescribed is praziquantel. How did Mr. Ibrahim likely get schistosomiasis? By swimming in dirty water. How should praziquantel be taken? What side effects should you expect after taking medicine? What advice should you give the patient? When should he be retested? All right. So basically, I told you that schistosomiasis is transferred through snail. Snail, what do we call snail in local language? You can drop that in the comment section. All right. So people who swim in dirty waters will likely have this illness. All right. Common to farmers, fishermen, and then people who use dirty swimming pools. So how to take praziquantel? You take with food to reduce nausea. If you chew it, to be very bitter, I think the drug is quite bitter. Yes, I think so. And when you're drinking, you drink with plenty water. All right. All right. Um, Side effects: nausea, vomiting, abdominal pain, slight abdominal pain, and dizziness. Okay. So now most of these side effects are usually due to the worms that are releasing their toxins. When the worms are dead, their toxins leak out into the body, and this can cause pain in the stomach and diarrhea. All right. If there's headache, you have to take paracetamol. All right, to reduce the headache. All right. What to do to prevent reinfection? You avoid contact with infected water. You improve sanitation. Then water that is around your area, you treat before you drink or before you use. All right. So usually when they finish taking their medication, they when they finish taking their medication, they usually do a retest in every 3 months. Okay, you check their stool or their urine to see if the parasite is cleared. All right. Then I didn't mention how is praziquantel taken. It's taken usually by single dose. Okay, or you split it over. It's two double doses that split it over 6 hours. All right, that is what do I mean? Single, you either give the patient the single dose once, all right, or you divide the dose into two and divide it in 6 hours. So you give first dose, now the next 6 hours you give the next dose. It's okay. So we have what is the next case study? Metronidazole. So Mrs. Ngozi, 28 years old, complained of bloody diarrhea for 5 days, abdominal cramps. This entamoeba histolytica. Bloody diarrhea when you have stooling blood. Okay, please note that. If you find a patient stooling blood, this is the condition. So 400 milligram 3 times daily, which is 8 hourly for 10 days. What is the most important warning you must give to Mrs. Ngozi? All right, why must she complete the full 10 days course? What common side effects should she expect? How can she prevent getting Amoebiasis again? What should she do if symptoms don't improve after 3 days? All right, so important warning you give to the patient. Let's see, what's the first question? What's the most important warning you give to the patient? I told you when taking metronidazole, you prevent taking alcohol 48 hours after the last dose because it will lead to what they call disulfiram-like effect. Okay, so part of the side effect is chest pain, fever, flushing, palpitation, and seizure, and sometimes death. All right, it can be serious and very unpleasant. All right, so let the patient know this. Okay, why complete the drug? Why complete the 10-day drug? Because it will kill the amoeba and the yeast and the cyst. Now, cyst is a form of inactive form of the bacteria. Okay, that is the bacteria is not divided. Remember, I told you when bacteria are not divided, sometimes it can antibiotics may not work, but in this case, metronidazole will work very well, very fine. Okay, so when you do not take it for the 10 days, it will only kill the adult and the live one. Then after some time, the infection will come back. All right, but when you take the complete dose, it kills the amoeba and the cyst, as the baby form that are yet to start being active. All right, so that needs to take the 10 days course. So major side effect of metronidazole, I don't know if I say this, is dark urine. All right, because when you are taking flagyl, notice that your urine becomes darker. So there's nothing for you to fear. That is just normal. Okay. Then there's headache. There's nausea. Then there's a kind of taste that metronidazole give to the mouth. It's known as metallic taste. So that's that for that. Ways to prevent reinfection: you drink safe water, hand hygiene, food safety. Then if there is no improvement after 3 days, you return to the clinic. All right. So that's that for that. We are rushing, so I think this is case study 5. As we will test our knowledge on aminopenicillins. So let's backtrack a little bit. Aminopenicillin is a class of penicillin. All right, it's an example, or is a class of penicillin where amoxicillin is the example. So under penicillin, we have natural, we have after natural, we have penicillinase resistant penicillin. Then we have aminopenicillin. Then we have extended release penicillin. Okay. Under natural, we have penicillin G and penicillin V. Under penicillin, for example, we have the clozacillin. Then we have under aminopenicillin, we have the amoxicillin. Then under the extended release penicillin, we have the amoxicillin plus clavulanic acid. Please don't joke with that class. So under aminopenicillin, we have David, 4 years old, diagnosis acute otitis media, ear infection. Amoxicillin prescribed 250 milligrams 3 times daily for 7 days. Mother says, can I stop when the pain goes away? Why must it be completed on 7 days if you better? Can amoxicillin be taken with or without food? What should you ask before giving a fair dose? What side effects might occur? What signs indicate David needs to return urgently? So we are going to check this. I think this should cover most of the important information about the penicillins. All right. Why complete all 7 days? If you don't complete it, bacteria are not completely dead. It can lead to resistance. All right. So you need to ensure that you complete the medication. Now, if the patient is taking the medication in the second to the third day, the patient will feel better. All right. So, but you have to take the patient to complete it exactly the 7 days. You can take the aminopenicillins with or without food. There's no problem. All right. Or other penicillins, you need to take it on empty stomach. Okay. Generally well tolerated. Now, what to ask before the first dose? So usually this question is trying to test our knowledge. That's number 3. What should you ask before giving the first dose? This question is trying to test our knowledge on what? Not just our knowledge on the allergic reaction of penicillins. Okay. So if you don't ask this question, it means that you may not know if the patient is allergic to penicillins, and it can lead to severe side effects. Okay. Then you may also want to ask if the patient is resistant to any other antibiotics. So if they mention any cephalosporins, you are now sure, okay, this patient is allergic to cephalosporin. It may necessarily be that they're also allergic to what? Penicillins. So possible side effects, we have diarrhea, we have rash, nausea, vomiting. Other than that, children or basically adults usually don't react to penicillins, okay, apart from those 10% or 5% that are allergic to it. So question 5, what signs indicate David needs to return urgently? Anaphylactic reaction, when there is a sudden change in David's physiology. For example, the way he's breathing, redness of the lips, swelling, fever, rash. Those are signs of anaphylactic reaction. You have to take David to the hospital immediately because he may eventually enter seizure, and that can be very, very disastrous. So you can then take the patient back to the hospital and report that he's allergic to penicillins. So this will only occur, number 5 will only occur if you did not ask the patient if the patient was allergic before, or probably this is the first time the patient is knowing that he's allergic to penicillins, which is also fine. All right, so case study number 6, 3rd generation cephalosporin. Baby Ade, 3 months old, diagnosis neonatal sepsis, admitted to ward, prescribed ceftriaxone 50 milligram per kg once daily IV. So why is ceftriaxone preferred for this baby instead of oral antibiotics? How should ceftriaxone IV be prepared and given? What should you monitor during treatment? What important drug interaction must you avoid? What is the advantage of ceftriaxone over other antibiotics? So basically, what all these case studies are doing is that they are trying to help you remember or take note of what? Of the nausea consideration that is attached to most of these antibiotics. So why ceftriaxone instead of oral medication? Sepsis is an infection of the blood. Okay, so basically what we need to manage sepsis is IV medications because there's fast onset, there's fast distribution, and it can actually address the issue faster than oral medication. Then also when babies are sick, they may not be able to swallow and they will start throwing up more frequently than usual. All right. Then how to prepare and give. You reconstitute with water for injection. So usually what do you boil the water and allow it to cool before you reconstitute. All right, or you use that's for the oral suspension, no? But for the injection, you constitute with reconstitute with water for injection. Then ensure that you do not reconstitute with any calcium containing solution. If you use calcium and many other, what to monitor? You should monitor for temperature decrease, monitor for vital sign stabilization, monitor for swelling and redness. Then also ceftriaxone can cause jaundice. All right. So monitor for jaundice in the baby. All right. Then monitor for allergic reaction too. Ceftriaxone will also cause allergic reaction, just like the penicillin will cause 10% of the time. So drug interaction, basically, with ceftriaxone is any calcium-containing solutions. Example: calcium gluconate, calcium chloride, Ringer's lactate. They will all cause interaction with cephalosporins. All right, so please pay attention to that. Do not give with any calcium-containing drug. All right. Then advantages of ceftriaxone. Ceftriaxone is usually given either 12-hourly or 24-hourly. It's broad spectrum. If you remember, ceftriaxone is a third generation cephalosporin. All right, has a long half-life, and then it can penetrate tissue very well. But all those ones are quite clinical. But majorly, what you just have to know is that it's broad spectrum. Cephalosporin is a third generation. Ceftriaxone is a third generation cephalosporin, and it can lead to a better treatment results. So we are just 2 more case studies to wrap up. I think I have about 9 case studies here. Macrolides is the next one. Mrs. Kemi, 25 years old, diagnosis community-acquired pneumonia. She has penicillin allergy, a documented penicillin allergy. So doctor gave her azithromycin 500 milligram once daily. So question 1, why is azithromycin good choice for this patient? How is azithromycin dosing different from most antibiotics? What should you tell her about when to take the medication? What advantage does azithromycin have over erythromycin? All right, first question. First question, why is azithromycin a good choice for this patient? All right, first of all, she's allergic to penicillin. So macrolides are the best alternative to use when there's an allergic reaction to penicillins. Okay, then macrolides are not cross sensitivity to penicillins. Only the cephalosporins have. Okay, then macrolides, especially azithromycin, is taken once daily, so it's easy for compliance. All right, and it's very tolerated. Okay. Why is the azithromycin dosing different from every other antibiotics? Is because azithromycin basically stays in the body for 5 to 7 days, so the half-life is very long. You understand? All right, and then it's usually present in the body for a very long time, and therefore can accumulate. So if you give it to a patient 500 milligrams today, 500 milligrams tomorrow, 500 milligrams the third day, as at the third day, the patient will have about 1.5 gram of azithromycin. You understand? Because the half-life is 5 to 7 days. So you are giving them cumulatively. So the concentration accumulates over the body and then leads to a better effect. All right. So you can take it with or without food. That's question 3 now. When to take it? You take it same time each day, probably every morning or 1 hour before food on empty stomach, because that's when it increases the absorption. Now, question 4 says advantages over erythromycin. Erythromycin is taken 6 hourly, as 4 times per day, 4 times a day. All right, and erythromycin is taken for 5 to 7 days. This one is taken for just 3 days. Okay, so that's for that. Then what's the last question? I think, when should she feel better and what if she doesn't? So when she feels better, she'll start feeling better after the second day, second to third day, because I told you that it's to accumulate, isn't it? Then if she doesn't, she should return for assessment, maybe do an x-ray, and then they will now know whether they are dealing with a resistant bacteria, then add any other antibiotics to her condition. All right. So the next example is ciprofloxacin, fluoroquinolones. Fluoroquinolones are the zacins, ofloxacin, ciprofloxacin. Remember that. So Mr. Olu, 40 years old, typhoid fever, ciprofloxacin 500 milligram twice daily for 10 days. Also giving antacid for stomach discomfort. So class, looking at this question, you already know that there's going to be a serious problem with this combination. Okay, why should Mr. Olu not take ciprofloxacin with antacid? What important warning about tendons should you give him? Ciprofloxacin is going to cause, okay, let's get the first. Why can't this drug be given to children? Why should they avoid? What should he avoid during treatment? What signs suggest the treatment is working? Okay, let's go back to the first question. Why should Mr. Olu not take ciprofloxacin with antacid? All right, don't take with antacid because antacid will bind and reduce the absorption rate. They will bind to whatever is in the stomach, usually medications, and then they'll form a complex that would prevent the absorption or reduce the absorption of the drug in the stomach. So usually space antacid between either 2 hours before or 6 hours after. All right. So you take antacid at least 2 hours before you take the drug, or 6 hours after you have taken ciprofloxacin. That's when you take antacid to allow the drugs to leave the stomach and absorb. All right. Then what is the next question? What important warning about tendon should you give the patient? So it can cause tendon damage and rupture. This is your Achilles tendon. All right, so stop the drug immediately if you feel tendon pain, or maybe there's swelling around your ankle or your heel, maybe you have difficulty walking. All right, you stop the drug. All right, so you avoid exercises that will strain the tendon if you are taking ciprofloxacin. Usually, this problem will affect elderly patients. It totally makes sense because the younger adults are still multiplying, are still growing, but elderly patients are deteriorating. So if you are taking ciprofloxacin, it may impact the tendon and affect the nerves. So the drug is not good for children because that's the question 3 now, because it will damage the cartilage, and it absorbs in soft tissue. I told you, so it will avoid bone absorption, bone growth, and then suppress bone marrow, which will also affect the availability of blood, white blood cells and red blood cells, and this can cause permanent damage to children. So what to avoid during treatments? Sunlight, it can cause severe photosensitivity. All right, avoid antacids and dairy products. All right. So caffeine can also cause caffeine and ciprofloxacin can cause drug-food interaction. Caffeine is a food, okay, and then can cause drug-food interaction and lead to the increased caffeine levels. It now look like you are high on caffeine, and when there's increased caffeine levels, it leads to alteration in the cardiovascular system, palpitation, and several other symptoms are associated with it. So signs that it is working is that appetite return, headache improves, no more abdominal pain, you feel stronger, and the likes. All right, so the last case study, as I'm here now, I'm very tired. The last case study, aminoglycosides. Examples are the gentamicins. Mrs. Amina, 55 years old, diagnosis complicated urinary tract infection with sepsis. Admitted to ward, gentamicin 5 milligram per kg. Remember, you don't give gentamicin alone. Now the doctor is adding ceftriaxone. Okay. All right. The nurses note that this patient has diabetes and takes a medication. So why is gentamicin given with another antibiotic? Remember, gentamicins are example of what? And you know that gentamicins are not supposed to be taken alone because what they are bacteriostatic. Okay, gentamicin given with another antibiotic, ceftriaxone. What two critical side effects must you monitor? What tests should be done before starting and during treatment? How should gentamicin IV be administered? Why is diabetes relevant to gentamicin therapy? Okay, so why do you add gentamicin with another antibiotics? The two drug work better. All right, covers better coverage. Okay, only gentamicin alone is not sufficient. It reduces the bacteria can be resistant to gentamicin. So two major side effects that you should note is nephrotoxicity and ototoxicity. Ototoxicity is ear damage, hearing loss, although temporary. The nephrotoxicity is kidney damage. Okay, this will also be necessary when we are answering question 5. So the test you should do for the patient, you will check kidney function test, serum, urea, electrolytes. I also check for hearing assessment, assess for hearing. Okay. So why is diabetes relevant? Because of kidney damage. You know, diabetes basically affects the kidney generally. So you don't want a patient that's diabetic to be on gentamicin because of the risk. Okay. Then there is also need for you to monitor kidney function test. You understand? Then also there's also need for you to provide a lot of fluid, water. All right. So that's that for that. Wow. I think I still have one more case study, but we'll stop here. We'll stop here, class. Thank you very much for your time. I really appreciate it. I am drained. I think I've done about 2 classes already. So hopefully on Monday we'll continue from where I stop here and do every other class that is remaining. Thank you very much for your time and see you next week. Bye bye.